Hello, my name's Mike Norwood. I'm a consultant at the Leicester Royal Infirmary. The talk I have given today is the acute abdomen in older people and how can we get it right. There are a number of themes that I wanted my talk to highlight. The first point is correct assessment. Correct assessment of patients is vitally important, and the only way we can assess patients correctly is by doing a good history and a good examination so that we can get the correct diagnosis. And I think one of the big problems that we experience, certainly in general surgery, is either medical patients who are admitted under our care and perhaps shouldn't have been, or patients with general surgical problems going to medical wards when they have a primary general surgical problem, because in our experience trying to get patients to cross back again can be difficult, and this can lead to delays in their diagnosis and subsequent delays in their treatments. The other important point that I'd like to make is that once a patient has had their operation, often these patients have got multiple comorbidities. They tend to have heart disease, diabetes, respiratory conditions. Often they're generally frail, they're poorly mobile, and they're usually on a large array of different medications. This is quite a complex challenge sometimes for general surgeons who are very good at surgery but not necessarily good at the more medical aspects of the patient's care. I think certainly in the post-operative care of these patients it's very important that we can try and get some integrated care with the physicians to try and streamline their recovery, to get these patients better quickly and out of hospital back home as soon as possible with minimum comorbidities and post-operative problems. I also mention the National NELAR audit in my talk, which is the National Emergency Laparotomy Audit. It's an audit that's taken place over about 20,000 patients, over 190 hospitals, and it's specifically looking at emergency surgery and patients having emergency laparotomies. That over 50% of patients having emergency laparotomies are over the age of 70, and that in this age group the risk of mortality is 6 times that of patients under the age of 50. Overall provision for these patients post-operatively in terms of being seen by geriatricians or medicine for the elderly physicians, the resources are very scarce and most patients aren't being seen. In order to correctly assess patients, it's very important that there is a detailed history. Now, there are a number of specific points that we need to look at in that. One point I like to make is that any patient who's had recent surgery, so surgery in the last few weeks, who may have gone home and come back into hospital, it's vitally important that the surgical team are involved because invariably there is a problem relating directly to their surgery. Another thing about the assessment is that it's very important that certain things aren't missed, and some of those things that can lead to problems are patients whereby they don't have their groins examined specifically to look for hernias, especially in patients who are obstructed. Equally, patients often don't have a PR examination, and this is again vitally important. Anyone who's not opening their bowels, is it just because they're constipated, or could it be that they've got a rectal tumour? Obviously this makes a big difference as to where these patients should go and how they should be managed. Again, there can be a number of pitfalls. Some of the things I think are very important. Firstly, taking a history of a patient who's vomiting, what they're actually vomiting is of great importance. If they've just brought up their last meal or merely retching, well, that's of little significance. But if they're vomiting large volumes of green or brown liquid, again, this is something that might or does indicate that they are obstructed. And I think another important point is if there's any uncertainty with these patients, the thing to do is to pick up the phone and to ring one of the surgical consultants or senior registrars on call, because we're always more than happy to talk to you. So really, in summary, I feel that actually the geriatric abdomen, so to speak, is a very common thing, and in reality it's it's the majority of patients that we deal with. The older you are, the more likely you are to have something go wrong, and that goes without saying. So other comorbidities, again, which makes looking after elderly patients more complicated. Integrated care is of great importance in these patients. Ideally, patients should be seen by an elderly care physician when they come in, certainly in the elective setting, but if we can get joined up care with geriatric elderly care physicians seeing surgical patients post-operatively, then this I think will be a great thing to take our service forward. Thank you.